صباح الخير عليكم كلكم. انا هاخد كل الاطفال بقى، هنسيب الكبار والكورنيا وهندخل في السفيروفاكيا. It's a rare condition which is usually bilateral, maybe prevailing in families. It is due to the non-attachment of the posterior zonules to the equatorial zone, yielding spherical lens. But it might be due to lax frail zonules with mobile lens. The lens may undergo subluxation, dislocation, whether in the anterior chamber or posteriorly, or leading to defective accommodation, defective vision. Despite that, the primary morphological abnormalities apparently lenticular in Spherophakia, still yet the glaucoma is the leading cause of blindness in these children. Okay. Because most of the patients are children, they might come with anteriorly dislocated lens in the anterior chamber, and it might pass unnoticed. Sometimes it can come after a month of anterior dislocation, where we remove the lens matter intralenticular within the capsular bag and then remove the capsular bag afterwards. In this case, because it has been since 2 months dislocated, we had a membrane surrounding the lens as well. We left that patient aphakic because she had markedly defective vision because of the glaucoma that she had. The patient might come presenting with unexplained, very high myopia, up to -22 diopters of myopia. Doing UBM, we can see that she has a very shallow anterior chamber and a markedly increased anteroposterior diameter of the lens. And these cases, we remove the lens because it's some sort of a refractive surgery, and we're scared of the movement anterior-posterior that it might result in pupillary block glaucoma. We remove it intralenticular, and then we remove the capsular bag, perform our peripheral iridectomy, and here we implanted Clo lens. I implanted it retropupillary. We invert the IOL and so that the vault faces posteriorly, and we enclavate the iris on either side. The patient may come with defective vision, and when on examination, we might find a highly mobile subluxated lens. To achieve removal of this lens through a very small incisions, we float the lens, the highly mobile lens, using high viscosity viscoelastic like Hedon GV, and then we remove the lens as mentioned before. And then I implanted Clo lens into the anterior chamber because this child was very young. He was 2 years or 3 years of age, and I implanted an intraocular lens to visually rehabilitate him. I implanted it anteriorly so that I might be able to visualize it if any complication happens. So we have other concerns when we get cases of Spherophakia. We have to perform thorough ophthalmic examination and systemic examination as well, because they might be having problems in their heart, problems in their brain, and we have to examine these things prior to their surgical intervention. We have several surgical challenges as the lens removal, because the lens is usually hypermobile. It is so unlikely that we can do continuous curvilinear capsular access. And the visual rehabilitation by intraocular lens poses another challenge, because if we put CTRs, it is very hard to put CTR in the capsular bag because it's such a small bag. This is the first thing. If we put an intraocular lens inside the bag in a case with progressive disease in the zonules, it might fall in the posterior cavity later on. So we're left with several surgical treatment options. We might fix the IOLs in the sclera using Prolene sutures, using scleral tunnels, using the Yamani technique. However, there's been a concern regarding the scleral fixation because it's dealing within the pars plana and the pars plicat of these children, which is quite unsafe for the vitreous base of these children and the retinal periphery. So I prefer iris fixed Clo lenses, whether anteriorly or retropupillary. So the take-home message is that Spherophakia is a challenging condition, starting from the diagnosis up to management. The story doesn't end by lens removal only. A thorough follow-up of the intraocular pressure, peripheral retinal routine examination are required. Thank you so much.
Thank you, Dr. Ghada.